Hi, this is Professor Schleich here. Welcome to our weekly lecture. This week I will be covering in the Coding Manuals, Chapter 9, Diseases of the Circulatory System, Chapter 10, Diseases of the Respiratory System, Chapter 11, Diseases of the Digestive System, Chapter 12, Diseases of Skin and Subcutaneous Tissue. To the right of my screen, you will see a document, and I've actually prepared something a little different this week, and we're going to go over some case studies along with viewing the PowerPoint. I'm hoping that this method will help you understand a little bit more about the official coding guidelines and how they apply to the coding for the week of these chapters, and also some of the more important things. The diagnosis, they're a little harder to understand. So if we'll get started. So let's just start with a little review of Chapter 12. To my left, I have my coding manual open, and I have it open to Chapter 9, Tabular, actually. So open that up, find Chapter 9. At the top, it should say Diseases of the Circulatory System. Our codes are I00 to I99. So let's review just a little bit of the PowerPoint. And remember, all PowerPoint are located in the files in your classroom or on the official website for AHIMA, and they're very good to review before you start your assignments for the week. So let's start. Circulatory system is always a little harder. As we know, there's some definitive diagnosis that, or big diagnosis, I should say, that take a lot of time and energy for physicians, facilities, and coders. So the first thing we talk about, obviously, for each one of our PowerPoints, we start out with learning objectives. And again, they're telling you right up front that this chapter, the concepts in this chapter may require extra study time. Coding of conditions within the circulatory system, diseases, and procedures require particular attention to definition and details, as of course they may make a difference in the reimbursement piece of it. At the conclusion of this chapter, what you must know about the coding diseases of the circulatory systems and related therapeutic procedures. So we're hoping in conclusion of that you will be able to understand and be able to apply the guidelines that they prepared for you, that AHIMA has prepared for you. So we're looking at some of the categories, and they just start out with and remember we have I00 to I99, so these are just a few. And you can see that there are myocardial infarctions, strokes, cerebrovascular, etc. So there are quite a few in depth. Also, the current terminology for acute conditions, or acute myocardial conditions, it's very good to review these. We have a STEMI or a non-STEMI is what we call those. And if you do not understand exactly what that means, my suggestion as we start on my document on the right side is that you do a Google or Bing search and pull up myocardial infarction, pull up cerebrovascular accident. Look at non-STEMI versus STEMI, the differences. The coding world will tell you, and you'll learn a lot just from coding because our books are very good with the definitions and they do direct you. But there are many guidelines in terms of applying the correct information to your code. So if you have an acute myocardial infarction, maybe it's new, less than 4 weeks, as you can see, our first sentence talks about, or subsequent acute myocardial infarction, or one that has occurred within 4 weeks of that myocardial infarction. The other system we review, make sure that you understand hypertension with heart disease, kidney, heart and kidney, cerebral, and retinopathy. Again, there are guidelines that are following this. So if you have a patient that has a diagnosis with hypertension with heart disease, you're going to go back into your Chapter 9 and review through the official guidelines. So you'll see right across from my document here that we are actually going to be coding out a patient with a rupture of the cerebral aneurysm caused by malignant hypertension. And I'm going to walk through that with you shortly. So I'm going to make my way through these PowerPoints, and again, I will not go through all of this, but I will breeze through it, and then it's your responsibility to hit those files, pull up those PowerPoints, and really you can take your time and review through each one. So, all right, so they do talk quite a bit about type 1 STEMI and STEMIs, the myocardial infarctions. Acute rheumatic fever falls underneath this. And we'll just hypertensive disease, as they said. Make sure that you are familiar with essential hypertension, primary hypertension, secondary hypertension, etc. So they do give you a quick overview, but if you're coding someone out like we are today, my suggestion to you with the rupture of cerebral aneurysm, I would Google what is a cerebral aneurysm, or just put aneurysm cerebral, and then hypertension, malignant. What is the difference? Benign, malignant hypertension. In this chapter, they talk quite extensively about hypertension and renal disease. So we have secondary hypertension, obviously, due to another disease or underlying condition. So, excuse me, 2 codes are required for that. One for the underlying condition, and then you need to sequence that. So how do you do that? You go back to these guidelines and review. Once you hit a patient that has this case, then you're going back to these guidelines to understand. Hypertensive crisis, again, someone that comes into our hospital with hypertension emergency will be coded under that, and depending on the circumstances, either a code from the 110, 115, 116 may be sequenced first. So again, it's something to look forward to. Is there an underlying condition that is causing that hypertensive urgency then? We have angina. You'll hear that a lot. There's 2 types, angina and unstable then. And so it gives you a little bit of definition of that angina. Angina pectoris, again, and then it gives the categories. So I'm not breezing through these, but it is something to familiarize yourself with, and I think until we actually code some of them out, the guidelines, maybe you're just reading them. So what I really want you to do is to focus on a diagnosis from these chapters, and then work through them, and then you'll understand how the guidelines apply, and you will not miss anything. So atherosclerosis, formation of lesions inside arterial walls, enlargement to large arteries produce that chest pain again. Chest pain would be an integral part of the disease, so you're not going to be coding out chest pain if they have one of those diagnoses then. So again, a very, very intense chapter. The cardiovascular is very, very, very intense and very deep. So it is a chapter that when I started out, new coders, that we did not assign to them, as they needed to understand the process and to review a few, how do I want to say it, easier diagnosis, so that you were grasping the actual process before you actually make your way into some of the harder diseases that you'll be encountering. So cardiovascular is one of the harder chapters out of CPT coding and your ICD-10 coding. So, okay, so you'll see familiar diagnosis. We have a cardiac arrest, obviously. And I think what's interesting about the PowerPoints, if you are like me, and I review through a PowerPoint, I get the title of that, kind of the gist of it, and then when I sit down to do my work for the chapter, I will say, hey, I think it was a note regarding this. And so I'll go back and look at the PowerPoint or breeze back into my textbook. So, all right, and then we are now hitting strokes as I move through these PowerPoints a little bit. And obviously there is different guidelines for that, acute stroke, sequential, etc. So you'll want to know there is, and I'm sorry, I'll back up one PowerPoint there. They do talk about the sequela. These may be permanent after stroke or remain only a period of time. So hemiplegia, paralysis, etc. is something that you code initially, and if it still lingers after so many months, then you would obviously pull that back out again. Okay. All right. And here we have VTE and DVTs, intraoperative and post-procedural circulatory complications. And again, they do a very nice job if you have someone that's been in surgery. Intraoperatively, maybe they have a cardiac arrest, post-procedural hypertension, etc. are some of the diagnoses that should be coded. We look at that for medical necessity. It also helps bump up the reimbursement. We'll look at that today too, in terms of how it affects reimbursement. Okay, then we're getting into the procedure system. This is a great overview for those of you that have already taken the procedure class, so be sure that you review this, as there may be a few of the procedure codes that you will follow through. So, all right, and that kind of hit that PowerPoint. I'm going to pull over my document here, and we're going to look at this. And I want to do this step by step, and we'll do this week just a little bit differently. I'm not focusing so much on those PowerPoints, but we're going to apply what you are reviewing. So this patient's diagnosis is rupture of cerebral aneurysm caused by malignant hypertension. Give me a moment to make sure that my recording is up and I'm sharing my screen. So the first thing we want to do is we want to determine the main term. So I'm going to do some elementary process here that you should already know. But when I read this, I read the rupture of the cerebral aneurysm. That was caused by malignant hypertension. I'm thinking to myself, wow, so do I code hypertension first because the aneurysm was caused by that? How am I going to code that out? Well, the first thing we're going to do is let's determine our main term. So for me, to hit my index, I am going to hit aneurysm. I'm going to look at cerebral and rupture because that's where my main term should focus on. And then I have to identify the hypertension and that it was malignant. So we're going to start, and I'm going to walk you through this just to make a full circle with you. And we're going to start with aneurysm. Take your coding manual, open it up, go to your index, and find the term aneurysm. So once you find aneurysm, you'll notice that there are some non-essential modifiers, anastomotic, artery, diffuse faults, multiple, etc., and the code is 172.9. Well, our definition is cerebral, so I'm taking my finger and I'm making my way down the column. And you'll notice different aneurysms. We have the aorta, arteriosclerotic, arteriovenous, excuse me, or some of those categories, and then we hit the brain. So that is, or cerebral, I should say, brain or cerebral. And you can do cerebral, go down to cerebral, and it will see aneurysm of the brain. I'm going to back up, I'm going to go to brain, and then we are looking at, excuse me, it was ruptured, correct? So we say rupture of the cerebral aneurysm. So I'm looking at brain, arteriosclerotic. It says code 167.1. And then we see ruptured, see hemorrhage, intracranial, subarachnoid. Okay? So just take a moment and just look through those just a little bit. Take your finger and go down through the brain. Did we hit the right one? And towards the bottom, you'll see ruptured, see hemorrhage, intracranial, subarachnoid. And that was exactly what we started with under arteriosclerotic. So if you didn't know it was arteriosclerotic, you could still hit the rupture. Okay, so we're going to make our way through the index. We're going to see hemorrhage, hit the H's. So hemorrhage is, I'm not going to give a page number as everybody uses a different coding manual, but we see hemorrhage, non-essential modifier says concealed R58. Now you're going to take your finger and you're going to make your way down. We're going to look for, as our previous index said, hemorrhage, intracranial. And you can take your finger and just read through all of those sites of hemorrhage. When we hit hemorrhage, we hit intracranial. It's non-traumatic, and I see a code of 162.9. Okay. Then our next term from the previous index was C, hemorrhage, intracranial, subarachnoid. So we go to intracranial, and the code behind it is 162.9. I take my finger, and I need to hit subarachnoid, and it says a non-essential modifier, which means it doesn't affect the code, non-traumatic or from, and we have a code of 160.9, but we're saying intracranial, cerebral artery. So subarachnoid intracranial, and we see the code of 160.7. So, quick overview of what we just did. We have a rupture of a cerebral aneurysm caused by malignant hypertension. I looked at aneurysm, cerebral rupture, and it took me to aneurysm, brain, which in turn ruptured says to see hemorrhage because it had ruptured, and it goes to intracranial, subarachnoid. We find those terms in our index, and we arrive at code 160.7. Take your finger and kind of go underneath there. You see there's a lot of intracranial, and if you could be more specific, and cerebral, etc., if they mentioned anterior communicating, then we could, or posterior communicating, then you would have a different code. So our code for now is 160.7. I'm going to hit my tabular. I'm kind of flipping through, and I'm hoping that you are joining me. All right, so our code 160.7 in my tabular reads non-traumatic subarachnoid hemorrhage from unspecified intracranial artery. It's ruptured, and you'll read underneath there the notes, ruptured cerebral aneurysm, and that's exactly what we see in our diagnosis, ruptured cerebral aneurysm. Underneath that, we have subarachnoid hemorrhage, etc. And it excludes a berry aneurysm, which is not included. So this subcategory also has the MCC, meaning it can be a complication of a principal diagnosis also, and can keep the patient in the hospital longer. So again, I move into my backtracking. So I do 160.7. I need to go back up to the beginning of that category, and that code starts with 160. You'll see to the left of that a little check mark with fourth, saying that you have to have a fourth digit, which we do. We have 160.7. There are excludes 1 and excludes 2, and they do not apply. This is not a sequela of a subarachnoid hemorrhage. And then above that, you'll see this section. It says cerebral vascular diseases, I60-I69. This is the section. It is in red in my book. It says use additional code to identify the presence of alcohol exposure to history, and there we have hypertension, occupational tobacco or tobacco use. So I'm thinking right there, it just told me that I need to identify the hypertension, okay? So we will take a look at that. I'm also going to come back to this. Well, let's do it now. Underneath, you'll see that we have the AHA 2014 third quarter, page 5. So what I have done, if I can find it, and it will come back up. I've actually, and some of you may have access to the resources on the encoder, and maybe not in this class, but eventually. So just to kind of follow through and give you the big picture, I'm hitting the AHIMA coding clinic, American Hospital Association coding clinic. I'm going to look at the year 2014. We're going to go into the third quarter. And then we have page 5. So for me, on this encoder, I just breeze through these, and I just look for my page 5 to see if it will apply to my diagnosis. So here's external causes of operations of war for page 5, which doesn't apply. And then we have page 5, use of imaging reports for greater specificity. So this is the one that does apply, okay? It's saying that the previous coding clinic advice has supported the assignment of more specific. This is the fracture code, obviously, so we're not using that. Oh, and I apologize, I'm not on the right one. This chapter 5, but I thought it was a different one. Sorry. Oh, whoops, it does too. Sorry. And then it says, for example, if a patient is diagnosed with cerebral hemorrhage or hemorrhage infarct, can the hemorrhagic stroke, can the imaging results be used to identify a specific vessel associated with these? So again, that is what they are stating. It is appropriate to utilize imaging reports to provide greater specificity of the anatomical site as documented by the physician. So as I just stated, if your imaging report is more specific than our unspecified code that we found, then you are able to utilize the imaging report to document the stroke or that infarct. So that is actually how you use your AHA coding clinic. Kind of cool. I love it. Nothing like having all the resources in the world. Okay, so, and you can do that for each one of those if you have access to a 3M encoder in any of your classes. All right, so now we need to finish coding out this diagnosis, and the last thing we have is malignant hypertension. So we're going to look up hypertension as our keyword in your index. So back to the index, and we'll find hypertension, hypertensive, non-essential modified, or parentheses, accelerated, benign, essential, idiopathic, malignant, and systemic. So it's telling you right there that malignant is included in that. And that code is I-10. And we should always, please do not sell yourself short. It's a learning opportunity, especially at the beginning coder, as you have time. Look under hypertension and then take your finger and just make your way down through it. You'll see that we have cardiorenal, cardiovascular, complicating, emergency, kidney, pulmonary, renal, etc. So really, it's a great opportunity to open your mind a little bit. As I said, if you are anything like me, it will stick in my head just a little bit when I do certain diagnosis that, hey, I think I read something somewhere. And that's what the coding is all about, is kind of using your memory, backtracking, thinking the big picture of your diagnosis and what you're trying to code out. Okay, so our code I110, we're going to hit the tabular, and you'll see I10 is essential primary hypertension. Includes high blood pressure, hypertension, malignant, that's what we want. Excludes this, and excludes number 2, essential primary hypertension involving vessels of the brain. So remember, we coded out I60.7, so they're telling you that you must code that also, okay? Must code. And then we have another American Hospital Association 2018 second quarter, page 9. So please take a moment and pop that up and review through what they have to say about essential or primary hypertension. Okay, there's just a guideline in terms of rules of that. So I10, we're going to back up, and that actually takes us right to the code. I10, we back up, and as you know me, I call it backtracking. So it looks like that is right above it. You'll see hypertension. So this is category I10. So right above it is hypertension. This is your section in the codes, the rules, guidelines underneath are to be applied to code I10 to I16. And you'll see right under hypertensive diseases, it says use additional code to identify exposure to, history of tobacco, occupational exposure, tobacco dependence, tobacco use. No mention of that. Excludes 1, neonatal, does not apply. Primary pulmonary hypertension was not diagnosed as that. And the second excludes says hypertensive disease complicating pregnancy. So those you must read. That is the beginning of your section. So if they mention history of tobacco abuse, you would be, it is alerting you that you need to code that out. So you go back to your index, follow through the same pattern, and see if that is the code we wanted. Okay, so I didn't do this with our first chapter, but we'll do it with our last code, or excuse me, our last diagnosis of the cerebral aneurysm. So we'll go back to the beginning of the chapter, and that's, we're looking at chapter 9, diseases of the circulatory system. The codes that these rules apply to are I00 to I99. So we have an excludes note. If you have any of those conditions, then you must go back to, go back to the drawing board and start to code out again that diagnosis. This chapter contains the following blocks, and your PowerPoint will tell you that as we started, and then it starts with acute rheumatic fever. But those are your guidelines. Excuse me, that is the chapter notes. Now we want to go back into the chapter official guidelines. So you just flip back one page, and we're looking at chapter 9, diseases of the circulatory system. So what we are seeing is that we need to code out hypertensive cerebrovascular disease. Okay, so that's what we are looking at. Are there any guidelines that pertain to that? So as a coder, it's your responsibility to know if there are guidelines that will help you code out hypertension or cerebrovascular accident, etc. So take your finger and go through your guidelines, and you see hypertension starts with A. Okay, then we have 1, hypertension with heart disease. 2, hypertension, chronic kidney. 3, hypertensive heart and chronic kidney disease. I am in the right before chapter 9 in the official guidelines. Then we hit, 3, hypertensive heart and chronic kidney disease. Number 4, hypertensive cerebral vascular disease. That should trigger something in your mind. Hey, guess what? I just coded out a cerebral vascular aneurysm. So I need to read this guideline in more depth, okay? And it says, number 4, hypertensive cerebral vascular disease. For hypertensive cerebral vascular disease, first assign the appropriate code for the categories 160 to 169, which we did. We coded out 160.7, followed by the appropriate hypertensive code, and we coded out I10 for essential primary hypertension. Explanation in the purple box. right there says hypertensive cerebrovascular disease requires two codes. The appropriate code 160 to 1 I-69 code followed by the appropriate hypertension code. So you know that you coded that out correctly because you went back to the guidelines. Now, let's follow through as I like the big picture part of it. Number 5, hypertensive retinopathy. 6, hypertension secondary, a great example. This is an example where the hypertension is secondary due to an underlying condition. Okay, so the patient has something that's causing them to have that hypertension. Then keep going down. Hypertension is a really big diagnosis. Everybody seems to have hypertension and is on some type of drug to control it. So make sure you're familiar with this transient controlled, uncontrolled hypertensive crisis, pulmonary hypertension, etc. And then just keep making your way down through the guidelines as you'll find intraoperative post-procedural and a perfect example of those. So I love the examples. They definitely help you understand what the guidelines are used for, and they help you to code out the appropriate diagnosis then. Okay, so I actually, in my document to the right here, I put official guidelines for Chapter 9, hypertension, and then hypertensive cerebrovascular disease is where we should have been. And then I did mention the coding clinic, the couple coding clinics are there, and you should be able to find those if you have access to the encoder. All right, let's just keep moving on. So I set up another one here. And we need to be in Chapter 13 now. And we're going to do respiratory. I love respiratory. Respiratory is always fairly easy. At least I think it is. It's more common diagnosis for us. Maybe better. We maybe better understand it, the respiratory system a little bit more. So let me move things around just a little bit. Here we go. Okay. So the second one that I'm looking at, I'm in the coding manual, Chapter 10. Open that up right away. You'll see that we're looking at respiratory, and so your method of madness may be different. Maybe you are going to take a look at the official guidelines, take your finger, make your way down through, and just see what is included in that chapter, and that's great. You can do it any way you like to. So the diagnosis that we're looking at is acute hypoxic respiratory failure due to a COPD exacerbation. So let me make my way down through our PowerPoints just to get us started a little bit. So again, at the conclusion of the chapter, what you must know about the coding of respiratory diseases and related procedures is what your goal is. Just take a look at the PowerPoint. You'll see what is included under here and some of the guidelines that will apply. Acute upper respiratory, influenza, pneumonia, all different types of respiratory and lung diseases, organized into blocks, which most of them are. Make sure that you know your current terminology. So at the beginning of the chapter, the following instructional note. When a respiratory condition is described as occurring in more than one site, it is not specifically indexed, it should be classified to the lower anatomical site. So for example, tracheal bronchitis is classified just to bronchitis, the J40. Bronchitis not specified as acute or chronic then. That's something you could either wait for the physician to tell you, do they have a history of this, is this an acute condition, etc. So, and then at the beginning of the chapter also, which you will find when you backtrack a little or if you're moving forward, use additional code to, when applicable, to identify the environmental tobacco smoke, dependence, etc. So here's on the tobacco part of it. And at the beginning of our chapters are some of the following. So use additional code to identify infectious agents. So did they grow something out? Let's say they have pneumonia and it took a culture. Did they grow out staph or strep, etc.? The virus, you'll be picking up that additional code then. All right. So some of the guidelines that will apply, again, acute exacerbation of chronic obstructive bronchitis and asthma, acute respiratory, they talk about influenza, ventilator associated pneumonia, also there are guidelines for that. And I'm just going to kind of start making my way through this. Influenza, acute viral infection. So this time of the year, it seems like we are definitely, or any time of the year, it seems like we're definitely in some of this respiratory, influenza A, influenza B, etc. So you may already know someone that has that. And H1N1 has been declared a regular human flu now as a virus, and the pandemic is over then. So again, these are the notes that you will find throughout the chapters in your official guidelines for respiratory diseases. So again, my thought process is I can read through all of these. You can read through all these until you start to apply them to an actual diagnosis, then you will understand. It is good, though, to just be aware of the different guidelines. So bacterial pneumonia, not elsewhere classified. Examples of bacterial pneumonia coded here are Klebsiella, Pseudomonas, Staph strep, and other types of bacteria. Remember, that is your bacterial pneumonia. Okay, pneumonia in diseases classified elsewhere. It could be a complication of another disease. So again, if it's in italic type, it cannot be listed as the first code or as a single code. You first must code the underlying infections such as Q fever, rheumatic fever, etc. So remember those at the top here. You see J17, pneumonia in diseases classifiable elsewhere, which you should have learned throughout the first official guidelines, that when it's in italicized, it means that you'll code the underlying condition first. Okay, so we just keep moving. I talk about the fourth digit, obviously. Here's some more acute bronchitis. It's giving you some of the organisms, or the bug we call them in the real world. Acute bronchiolitis, a lot of our kiddos have that in our PEDS unit. Lower respiratory, lots of bronchitis today. It seems like COPD, is that caused by smoking, etc. So you'll find those codes also. Emphysema associated with that. And as you notice to the right, we are going to be coding out acute hypoxic respiratory failure due to COPD exacerbation. So this is one of the chapters guidelines that you will be using. COPD is J44 telling us, and then it gives us a little bit of a description of that. Can be present with acute infections such as acute bronchitis. There are several forms of COPD, and that is chronic bronchitis, obstructive asthma, or emphysema then. So J44.9 is used when a specific type of COPD is not documented. Okay, then we have J44.0, obstructive pulmonary disease with acute lower respiratory. COPD with acute exacerbation then is J44.1. And COPD is a one-word diagnosis and is coded as J44. COPD exists in several forms, as they stated. We have asthma. I'm just going to keep kind of making our way through. Acute exacerbation of asthma with exacerbation is an increase of severity in the disease or symptoms then. Core status asthmaticus is acute asthmatic attack and requires emergency care. So bronchiectasis, lung, black lung, hypersensitivity, pneumonitis. And then we get into the other categories for other respiratory diseases. And you'll notice a lot of those are towards the end of the chapter. I love this PowerPoint as they've started to add this because I do a lot of the surgery floor, intraoperative, post-procedural complication and disorders. So again, tracheostomy complications, acute pulmonary insufficiency, post-procedural pneumothorax, and air lead. Of course, that will keep a patient in the hospital longer. And then we hit the respiratory failure. And again, looking at our diagnosis to the right, we have acute hypoxic respiratory failure due to COPD. So that respiratory failure hits category J96, inability of the respiratory system to supply adequate oxygen to maintain proper metabolism or to eliminate carbon dioxide. Respiratory failure is a consequence of another disease, obviously, such as heart, lung, sepsis, trauma, or poisoning. Again, review the codes J96.0 to J96.9 for acute, chronic, and acute and chronic respiratory failure. Sequencing of the diagnosis of respiratory failure, which may hit you with the diagnosis that we are working on. So various coding rules and guidelines may be principal or secondary based on the circumstances of the inpatient admission. Chapter-specific guidelines follow for obstetrics, poisoning, HIV, and newborn. When a patient is admitted in acute respiratory failure with another acute condition, the principal diagnosis will not be the same in every situation. So there we go. Here is myasthenia gravis, again, diagnosis. Here's one. The patient with emphysema develops acute respiratory failure. So let's just say the patient is admitted to the hospital to treat the respiratory failure. Your principal diagnosis is the acute respiratory failure. Secondary diagnosis is emphysema. Sequencing, that's still on sequencing of diagnosis. Number 3, the patient with a congestive heart failure is brought to the ER in acute respiratory failure, intubated and admitted. Physician documents the acute respiratory failure is actually the reason for admission. So if they're coming in just for that, you're going to code out your acute respiratory failure, and then your secondary diagnosis is congestive heart failure. Sequencing, again, we're still on respiratory failure. We have example 4, a patient with asthma and status asthmaticus develops acute respiratory failure, admitted to the hospital for that respiratory failure. Again, principal diagnosis is acute respiratory failure with the status asthmaticus as secondary. Example 5, patient admitted during the postpartum period as a result of developing a thromboembolism or pulmonary blood clot leading to respiratory failure. So your principal is thromboembolism, secondary is acute respiratory failure, kind of flips that around. 6, patient is diagnosed having overdosed on crack cocaine, admitted to the hospital in respiratory failure. So principal diagnosis is poisoning by crack cocaine, and then your secondary diagnosis is acute respiratory failure, as they wouldn't have been in respiratory failure if they hadn't been to crack. 7, patient admitted with respiratory failure due to pneumocystis carinii pneumonia, which is associated with AIDS. Then you would go back into your HIV chapter, which was chapter 1 that we just reviewed, and to determine how to sequence out your HIV with respiratory, and also your respiratory section, chapter 10, it should identify that, or it will tell you to go back to your other condition. So, all right. Our next, number 8, patient is admitted to the hospital with severe staph aureus, methicillin-resistant, methicillin-susceptible sepsis, and acute respiratory failure. So you're going to code out the MRSA and the secondary diagnosis of severe sepsis and acute respiratory failure. Again, you're coding basically what they're coming in for. Bronchospasms, definition, respiratory system, these are your coding procedures for those. So you'll see word operations are always important, obviously. So this is UV in the bypass excision, insertion, release, and resection. Again, they just get into some of the body parts. Continue with the body parts. This will help you a little bit if there's any procedures like any endoscopic procedures. Are they open, percutaneous, endoscopic, etc.? All right, we're almost on the end of this. And then they talk about qualifiers, obviously a biopsy. So again, if there are any diagnosis, I don't teach the classes not over the procedures. You've already had that. So, and that is the end. So we are going to get started as coding this out. So to the right, you are looking at my document that states principal diagnosis, acute hypoxic respiratory failure due to COPD. So the official guidelines are chapter 10. So we're going to code this out, and I have tore it down. And so my first diagnosis should be, I guess I didn't put that there. I apologize. My main term should be, I'm going to type that in there right now. And you're going to put failure, obviously. We're going to do respiratory. Again, we're kind of backtracking again, hypoxic. And then we have COPD, chronic obstructive pulmonary disease. I'm not going to type that out. It's exacerbation then. If I can spell that. Okay, so let's get started. Start our index. And we're going to start with failure. And I hope this helps a little bit. It's kind of, I'm trying to put the big picture together for you in the coding sequencing and using the guidelines. So by now, people should have be at this point in time in the process. So hit failure, and let's hit respiratory. Take your time, make your way down through. All right, so we hit respiratory. And we see that We have respiratory, and it's J96.90 with hypoxia, and we have J96.91 acute, and they are stating it is acute. So again, I should add that to my main term, which I can. Let me write this on here. So I didn't put acute, and I should have. I apologize. Acute is a big part of that. Okay, so our code then, we will hit your respiratory, then hit acute, and it says with hypoxia. And the code you're looking at is J96.01. J96.01. Okay, let's hit our tabular for J96.01. And again, class, now I'm going to start moving through this. But take your finger and make your way down through the rest of that respiratory, just to kind of get a big picture, open your eyes, a little bit to what's included in the respiratory. All right, so we'll be towards the end. And we have J96.01. It says acute respiratory failure with hypoxia. And beside it, it means it can be a complication to the stay, a major MCC and HCC. We're going to make it up to, that's a subclassification. Our category is J96.0, and it's acute respiratory failure. And then that's the classification. Then move up to the category, J96. To the left says we need a fourth digit. You can't just use J96. Respiratory failure not elsewhere classified. Excludes acute respiratory distress, cardiovascular, newborn, post-procedural, respiratory arrest, and failure. Those do not apply. And it tells you that it is a CC. For CC and MCC codes in 96, again, these can be complications for that hospital stay. So our correct code is J96.01. Our category is other diseases of the respiratory system, J96.99. You'll see that in red. Take your finger and you're going to make your way back to the beginning of the, that was our beginning. We're back to the beginning of the chapter. Chapter 10, and the codes, the guidelines apply to codes J00 to J99. I'm at the very beginning of the chapter above code J00. You'll see a note. It says when respiratory condition is described as occurring in more than one site, not specifically indexed, it should be classified to the lower anatomical site, and that's what our PowerPoint told us. Then use additional code. We do not have any of those. Excludes 2, tells you if you have any of those diagnoses listed, then you need to add a secondary diagnosis or go to that. And then the chapter contains the following blocks, J00, J06, etc., and all the way down. So we are looking at hypoxia. So let's go back and finish coding this out before we get into our guidelines. And you can do this differently. You can hit the guidelines and review the code J06.09, the acute respiratory failure due to COPD. Now we're going to pick up our code for chronic obstructive pulmonary disease, which is always a tricky one to find, and I apologize, I know it by heart, so bear with me. In the index, we are going to, let's just take it apart and see chronic obstructive pulmonary disease. So for me, I want to go to pulmonary, but I don't know. I think it's going to tell me C condition, and it does. It says C condition. Okay, so let's try obstructive. And you may have a different method of madness. So we have obstructive, and we have airway, which is a J98, and that is what we're looking at. Can we be more specific and just be under the pulmonary? So we have airway, we have chronic, we have due to. Let's take our finger and make our way down through those columns and see if we can't find chronic obstructive pulmonary disease. We see pulmonary valve, but we don't see right? We do not see anything more specific. So we are going to stay within the obstructive pulmonary and its airway. It is chronic. And so we are looking at a diagnosis for obstructive pulmonary disease with acute exacerbation. And I'm going to have you just keep looking. And it will be, we have chronic is J44.9. It's never telling us that it is chronic. We're going to hit J44.9. We'll give you just a minute and let you kind of look through that. You can also go to disease, and it will tell you to go back into that. Yeah, we're going to try chronic, just not chronic disease. Let's see what we have under disease. Okay, find your way back. I'm going to give everybody a chance just to review that. Let's go to disease. I kind of got to start at the beginning of it. So we can find disease. We can find lung, which it is of the lung. We can find obstructive. And we have the J44.9. But what we're looking for is chronic obstructive pulmonary disease. Let's just keep looking through the index. So I really want to find chronic obstructive pulmonary disease. We have exacerbation is our key word. So I see obstructive with, then we have acute, but then it says exacerbation. So we have a J44.1. Let's keep that one in mind. Okay. Now, we found something there. Let's go still to disease. Let's go to pulmonary. But it also says see disease of the lung, and that's where we were at. But as we make our way down through that, we have pulmonary, chronic obstructive, which is what we want, and I'm feeling better about using the index. Pulmonary, see disease of lung, which we did. Then we have chronic obstructive, that's what we have, COPD, and it is with exacerbation. And exacerbation means, that's my point I wanted to bring out without giving it away. But when you look at the index and you look at disease and you look at pulmonary, so see also disease lung, and again, it did tell us that it was obstructive with acute exacerbation, but it does say chronic in parentheses, the J44.9. I'm under lung obstructive chronic J44.9, so it does say chronic with, and it is acute exacerbation. Exacerbation means it is an acute condition happening right now, not as we're classified. But if we look at disease and we look at pulmonary, we make our way down, and it does state right there chronic obstructive with exacerbation. So as a beginning coder, my thoughts are that you probably would end up there. I just, how do I say this? We code out so much of it that sometimes you forget how to utilize the index because you write to the code or the information. So the code that we want is J44.1. Let's take a look at J44.1. And we see chronic obstructive pulmonary disease with acute exacerbation, exactly what we wanted. Had we used the code that we initially kind of looked at, J44.9, it just says COPD, or chronic obstructive pulmonary disease, unspecified. And it doesn't really give us and it doesn't know to say, hey, if this is acute exacerbation. So, and again, here's another trick as you start to code is that there are under the category J44, there is J44 0, 1, and 9. So you may want to look at the big picture of that too. So we're looking at the code J44-1, chronic obstructive pulmonary disease with acute exacerbation. Read through your notes, okay? Do we have any of that? We have a coding clinic. You can go to that and review through it. They're telling you a tip. Exacerbation of COPD should not be assumed based upon the worsening of a concomitant respiratory disease or when COPD is described as end stage. And then a tip, assigned 43.9, when COPD exacerbation with emphysema is coded. So again, so important to read your notes. Obviously, we don't have any of that. It is not mentioned. Then we go back up to the beginning of this category, J44. To the left, we have the little red box with it needs a fourth digit, which we do have, J44.1. And then read through the includes. And then it tells you in red, code also type asthma, which we don't have that, and excludes. It names off several excludes, which we do not have any of those diagnoses listed. And again, you have a coding clinic there, American Hospital Association coding clinic to review. Okay, so again, J44 is your category. So I'm going to go to the beginning of where these codes start, and that would be right above the code J40, chronic lower respiratory diseases. Codes J40 to J47 excludes bronchitis, excludes 2, cystic fibrosis we do not have. Okay, so that is the beginning of that section. Now we want to go back to the beginning of the chapter and see if we have any notes that pertain to our code J44.1. And the notes above the code J00, that is where your chapter starts. Note, and it tells us respiratory conditions described, use additional code, excludes, and the chapter. So it's kind of nice we stay right in the respiratory with both of these codes, obviously. So you got a double whammy with review of the category section and the chapter. Now we need to know how are we going to sequence these out. So you're thinking, hey, you've got acute hypoxic respiratory failure due to COPD exacerbation, which is also acute. Which one of these should I be coding out? So let's go back to our chapter guidelines for 10, diseases of the respiratory system. We start right before the chapter. You have chapter-specific guidelines and coding examples, and they start with A, which is COPD and asthma. 1, and then B is acute respiratory failure. And bingo, that's what we have is acute respiratory failure. So they're telling us that acute respiratory failure as a principal diagnosis should be coded out as your first diagnosis. And so that acute hypoxic respiratory failure due to COPD exacerbation. So again, you can follow through with this paragraph, includes in subcategory J960, which I talk about category, subcategory, subclassification. Take your finger, make your way through those. They'll help you understand that. So we have acute and chronic respiratory failure. It may be assigned as principal diagnosis when it is the condition established after study to be chiefly responsible for occasional admission to the hospital. And the selection is supported, again, that alphabetical index and tabular. That's why I kind of went through that a little bit more detail. However, chapter-specific coding guidelines such as obstetrics for HIV newborn that provide sequence direction take precedence. So again, if you have those diagnoses, you stay right here and follow the diagnosis. So the example that we did acute hypoxic respiratory failure due to COPD. So again, this is the example that you will be using for that. Okay, I'm hoping that helps make a little bit more sense of our guidelines then. All right, we're going to, let's see, breathe into our next chapter, chapter 11, chapter 14. Let's take over here. And we are going to talk about the digestive system. I love digestive system too. It's fairly easy. Don't all of us have some kind of a digestive issue somewhere along the way? So I just picked a code. I'll make this chapter a little easier, but code out acute diverticulitis. And I'm going to let you do that, and then that can be part of your lecture assignment for the week and report back what the code is for that. on that piece of it. So I pulled up the PowerPoints again. What do you know about diseases of the digestive system and some of the related procedures? And if you go through and look at our chapter 11, open up your coding manual to that tabular, right before your tabular, you'll notice that there are no specific chapter guidelines. It is reserved for future expansion. So again, fairly straightforward. Here's some of the diseases of that cavity. Again, be familiar with the terminology that is included in that. There could be codes that are combination codes. Use additional code. Obviously, code out the underlying condition that's causing the patient to come into the hospital. Always think of that when you're coding something out. What is causing them to come to the hospital? What was the focus of the care? So again, as I make my way through this PowerPoint a little bit, just keep open mind. And again, so you really code some of those out. You'll refer back to that. So basically, your notes underneath your codes are really what is going to be important. We code out a ton of cholecystitis, acute, chronic, etc. The cholecystectomy, and a lot of those come into the hospital through the ER, which a cholecystectomy kind of depends. Can it be an inpatient procedure, or they like to do those as an outpatient procedure if it coming in as elective? Then we hit the procedures related to the gastrointestinal system. You'll have bypass, drainage, reattachment, supplement, etc. So refresh your mind in terms of the ICD-10-PCS coding and your body parts, obviously. Always important to put all that together. And then obviously the approach. Approaches are pretty much the same. And again, your possible qualifiers, your root operations again, and so forth. So, and you'll find that even in your digestive system, we do a lot of repairs, it seems like. Hernia orifices, again, people come in with diverticulitis that they can have a colon resection, colonoscopy, etc. So there are some pretty in-depth procedures in this chapter. All right, and that was the chapter 11, Disease of the Digestive. And that is codes K00 to K95. All right, so one more. And that is the, you're in your coding manual, chapter 12, and we're doing diseases of the skin and subcutaneous tissue. The codes are 1100 to 1199. I'm going to bring up our PowerPoint for diseases. And again, as I stated, you have access to all the files. If I breeze through too fast, you can pull those up and even just kind of follow through. And those are located in a textbook in the beginning of your coding manuals and also on the website, CMS website. All right, so skin and subcutaneous tissue, fairly straightforward chapter. Another tip maybe to students is to just open up chapter 12, and look through the diagnosis that you will be encountering for this chapter. Like we said, it's fairly easy. You'll see a lot of diseases of the skin and sub-Q and some of the procedures. You have infections, dermatitis, radiation, intraoperative complications. Again, they mentioned review notes at the start of the chapter. Again, it identifies conditions in other chapters that may be coded with diseases of the skin. So again, use additional codes to identify infectious agent or the bug. What do they have? That staff? Do they culture the skin? Do a biopsy? What did it come back as then? Skin conditions may be caused by drugs. So again, we know that that's allergic contact dermatitis. We talk about pressure ulcers, and as we go along, the one that I've chosen to code out a patient diagnosis, we have a stage 4 pressure ulcer right heel, 9/10 that invades the muscle and fascia. Stage 2 pressure ulcer of the left elbow. And so again, I put pressure ulcer stage codes, pressure ulcer stages is what we will be looking at. And so there are identifiable guidelines for this to be coded out. And so it's a complicated one, but we'll just take a quick look at some of that. So what we're looking at, your chapter 12 guidelines, pressure ulcer stage code. So if you knew nothing about that and you saw this diagnosis, but you knew there was a guideline, you could start right there. So the PowerPoint states pressure ulcer stage codes, stages 1 through 4, unspecified stage, unstageable. Assign as many codes from the category L89 as needed to identify all pressure ulcers that are present. Okay. And hang on here, just gonna make a note of that PowerPoint. Then we move up to unstageable pressure ulcers, documented pressure ulcer stage again, and those are found in your alphabetical index. So we do have it documented. And then the guideline pressure ulcers documented as healed, which is not true here. Pressure ulcer documented as healing, different, sorry, healed and healing. All right, so we have a pressure ulcer evolving into another stage. They're two separate codes. We have non-pressure ulcers also. Again, so there are many guidelines for those pressure ulcers and why it's definitely a bumped up chapter for official guidelines because we're seeing more and more people coming into our hospitals because of laying in a nursing home, et cetera, and they'll have a pressure ulcer from something. So we have cutaneous abscess and cellulitis, and there are codes for that. Lymphangitis is another diagnosis, or dermatitis will be hit in this chapter. Again, just familiarize yourself. Urticaria and erythema, again, we know the definitions of both of those. The SJS syndrome, toxic or TENS, they'll call it. It says also to use it to show and use additional code to show adverse effect of a drug or associated manifestations of that. We have radiation-related patients that are coming in for cancer and being treated with chemo or radiation would meet all of these categories. Solar conditions, again, we have nail and skin. A decubitus ulcer, I do see a lot of decubitus ulcers, especially for people that are bedridden. So we code out a lot of those. If they're gangrene, are they going to lose their leg? Are they going to do an amputation again? So those are one of our high diagnoses also, and it gives you the stages of that, 1, 2, 3, 4, and your physician will give that stage to you, and if they don't, that's when you query the physician and ask for that. Pressure decubitus ulcer, unstageable deep tissue, again, non-pressure underlying conditions. Then we get into our procedures for skin and breast, root operations. Be familiar with those, which you probably are. They're specific to the skin and body part. And our root operations are being discussed also. Lots. Yeah, I'm not going through all those. Excision of a lesion. Again, you'll have excision, grafting, debridement, excisional, non-excisional. Excisional debridement is very, very deep. Subcutaneous tissue and fascia, again. Refer to that table when you're coding those out too. So, all right. So let's just take a quick, I know I'm getting kind of long into this presentation, but it's some good chapters and good information. So to start, we always want to start with our codes. So diseases of the tissue, skin and subcutaneous tissue, again, we're going to start with a pressure ulcer. So you would start in your index again. We're going to be in L89 codes because they stated that. So we're looking at a pressure ulcer. So in your index, I'm going to say you're going to start with ulcer. They have an ulcer and it is tagged as a pressure ulcer. So find ulcer and then take your finger, and I'm going to just give you a moment and I'm going to let you look down through, take your finger and go down through each category, each column, I apologize, each column. You're going to be looking for pressure, and you'll see pressure and pressure in parentheses, pressure area. It says code L89.9 with a check mark saying it needs to have another digit. And then you will be able to code out your different stages then. So we have a stage 4, pressure ulcer right heel. So we're going to start with stage 4, and we're going to go to heel. And it looks like our code will be L89.6. So I might want to write that down, L89.6. We have stage 4, so then let's hit our tabular and look at L89.6. And obviously we are going to have more codes than that. So we have L89.6, and it says we need 5 digits. So L89.6 only has 4, pressure ulcer of the heel. We said L89.6, and then we need to find the stage. So we're looking at L89.6, and it is of the, I should have typed that out, but it is of the right heel. So we're looking at L89.614. Pressure ulcer of right heel, stage 4, again. So we'll move back up to the L89.61 pressure ulcer, and we want to find the beginning of our section. And that starts with L89 pressure ulcer. So you see it includes bed sore, decubitus, plastic, pressure area, pressure sore. Excuse me. Code for sting associated gangrene, which we do not have. We have an excludes, decubitus, diabetic, non-pressure, skin, varicose. We have the American Hospital Association coding clinic, and then it gives us the tip. Okay, so you'll see though, excuse me 1 minute. All right. So we are, excuse me, I'm back. Sorry for coughing. I'm still in the tabular here, but if you look at the 4 stages of a pressure ulcer, it's very cool. It's just under the code L89.0. You'll see the dermis, the muscle, the fascia, the deep tissue, and the bone. So it's kind of a cool staging of that. And again, the section begins right at the L80. Now we'll go back to the beginning of our chapter, which is chapter 12, diseases of the skin and subcutaneous tissue, L00 to L99. It is an excludes 2 note, certain conditions, complications, etc. Neoplasms. If you had any of those, diagnosis, you can take a look at that and be coding those out also. This chapter contains the following blocks. So again, different what you'll be coding out the diagnosis that are included in this chapter. Then we need to code out the rest of our diagnosis, which will do the same thing. And you're going to code out the pressure ulcer of the left elbow. So a different site, left side, and that is only a stage 2. So you can make your way back through that. I'm sure you'll be able to find that code. It's just as easy to find as we did for the stage 4. You would have that second code. And again, now let's look at our chapter guidelines. As you turn to chapter 12, chapter-specific guidelines with coding examples, there are lots of ulcers you'll see. So A, it says pressure ulcer stage code. Pressure ulcer stages, unstageable. Documented pressures, number 3. 4. Patients admitted with pressure ulcers documented as heal. 5. Patients admitted with pressure ulcers documented as healing. 6. Then we have non-pressure ulcers. guidelines for this chapter, and that is it. So basically, your entire chapter guidelines cover the pressure ulcers. And our first guideline, pressure ulcer stages, is number one, is what you're going to be looking at. So as I made my way down through that, your example is right there, stage 4 pressure ulcer, and your codes L89.614 and L89.022. So it gives you the explanation that the patient has a right heel pressure ulcer documented as stage 4, and that the left elbow is 2. Combination codes from the category L86 identify the site of the pressure ulcer as well as the stage. Assign as many codes from category L89 as needed to identify all pressure ulcers that the patient has. So again, very important in terms of treatment and care. We do a lot of studies at our facility to do these pressure ulcers. We have wound care nurses that take a look at this and they document, and then they'll go back and do studies and say, what did we do? How did this pressure ulcer get up to stage 4? Did they come in with a stage 4, or did we not turn the patient, etc.? So it's kind of used in terms of quality also in many different facilities. So, okay, thank you very much. I'm running out of breath, and I hope you enjoyed the lecture this week and learned a lot. Remember to get into your coding clinics, review those guidelines if you have that opportunity, and just start to look at the big picture of the coding. Always the fun part. Thank you very much and enjoy your day.